The next one that is quite important is a genetic mutation profile. And we pay a lot of attention to this genetic aberration called P53. It could come in as mutations, it could come in as deletions. Generally speaking, we group them together as aberration, but we do know that mutation weighs in more heavily, in the outcome prediction. So we learned from previous, prospective studies using chemoimmunotherapy that for those patients with TP53 aberrations, the survival data compare with others that do not harbor this mutation are much less favorable. So we're talking about, overall survival less than 2 years compared with others, which could be more than a decade. So that makes a huge difference, right? It doesn't mean that we won't offer chemoimmunotherapy, but we think very actively from get-go, what are the backup options for those patients should they not respond to chemoimmunotherapy or relapse early on? Should we be thinking about more smart medicine with target therapy that could be incorporated in the initial therapy of those patient cohorts? And then, we also have a more old-fashioned traditional parameter that is morphology-based. So a lot of people have heard about a subtype of blastoid or pleomorphic subtypes, which is essentially what the tumor tissue appear under the light microscope. But now that we can correlate those morphological observations with other factors,